Our last speaker is Dr. Arif Shaikh, and he will be discussing some very interesting cases with us. He is the Medical Director of Catering Network Radiologists Incorporated. He is the Director of Targeted Radionuclide Therapy and Cardiovascular Nuclear Imaging. He leads multidisciplinary thyroid and endocrine tumor boards and runs a targeted radionuclide therapy clinic. He has extensive teaching experience in multiple specialties: nuclear medicine, radiology, cardiology, radiation oncology, general internal medicine. He is radiology quality assurance officer for peer review activities. I'm thrilled to present our distinguished nuclear cardiologist, Dr. Shaikh, in physical appearance.
Shukriya. Good morning. It's great to see everybody here Sunday morning. The previous two talks have been A, more scientifically based, B, have talked about incrementally adding on calcium scoring or looking for calcium atherosclerosis on scans. With the advent of cardiac PET, now we can do myocardial blood flow. And the issue with blood flow, that we talk about, what's been mentioned is that we can potentially find additional coronary disease. And again, I'm currently at a community hospital. We're doing cardiac PET. So we're not at an academic center. But we've really been blown away that myocardial blood flow, if you start really looking at it carefully, it is like reading an entirely different scan. So aside from what the two speakers have mentioned, I will show you what potential impact myocardial blood flow really has. So again, this is more a case-based review, so I'm going to be light on the science. I want to try to make this interactive. Okay, so everybody please raise your hands or whatever, or maybe I'll throw out a question to you. And I just want to show you the approaches in interpretation. It's not to show that you should use this cutoff or that cutoff, but that being said, so why do we want to do cardiac PET? I mean, not going to the appropriate use criteria, but generally, why do you want to do it? And just ask somebody. They'll say, well, we want improved accuracy, sensitivity, specificity. That's appropriate. Prognostic significance, yes. An enhanced understanding of cardiovascular status, fine. Inappropriate. One of the cardiologists wanted to read cardiac PET, and he started reading it. And then when he started reading it, I asked him why, and then he started we're getting all these false negative cath, or false positive PETs because we get negative caths. So why do you want to do it? Why are you doing PET? Well, I want to know which patients to cath. As a wrong answer. Okay? You have to understand what's going on and how cath fits into that. It's also not a one-stop shop that I find everything about the patient. I don't need to do anything else in terms of imaging. Wrong answer. Okay? It's an entirely new understanding of what we are going to do with the patient. Okay, so what do we PET? This should say it all. This is a great looking scan in a patient whose BMI is 70, right? I mean, with SPECT, this is, anybody's guess what that's going to look like. But that's what we start off by doing, and that's why PET, just that picture speaks a million words. I'm going to give you a brief primer on how to read PET studies. Again, whether it's PET or SPECT, what do? You evaluate the splash images, you look at the gated images, that's fine. The previous speakers have talked about looking at the CT attenuation correction. Now, the thing is, you notice all speakers will talk about using, let's say the formal calcium score was this. In this, we don't do formal calcium scores. We say mild, moderate, severe, and there is actually a paper out there, which I haven't showed that if you do a qualitative assessment, you can get into the similar ballpark of getting a formal calcium score. So you don't actually need a formal calcium score, but you do need to go over the CT images to get an assessment of it's mild, moderate, or severe. The other things that we look for is something called splenic switch off. Now, we do that with regadenoson. We're doing our stress test with regadenoson. I understand many of you are actually doing adenosine stress testing. But what happens is, between rest to stress, you actually see a relatively decreased perfusion in the spleen, which is a good indicator that the regadenoson actually worked, because actually it turns out vasodilators may not work in some patients, and that I'll bring up. an issue. So there are other cardiac findings, and then you do ancillary findings too. So if you look through the ASNIC guidelines, there is actually a paper, it's a pretty thick paper, of what to look for in the hybrid part of the imaging. I think it's an overkill, because if you look for all that and put it, your CT report's going to be longer than your cardiac part. So, but, point being taken, I show it to my cardiologist, you want to read hybrid? This is what you have to do to provide standard of care. A lot of them back off immediately. Okay, so old cases, again, IQ SPECT is a Siemens cardiac-specific SPECT CT, okay? It's a cardiac-specific SPECT CT. So this patient had a cardiac-specific SPECT CT, non-attenuation-corrected images. Images look relatively fine. Maybe a little bit of apical defect here, very, very slight. Most of us would probably ignore it. Now go to the attenuation correction images, which are the real images, right? And all of a sudden, oh, okay, wait a second, that defect becomes a little bit more, which is unusual. Usually it's the defect that should go away. It shouldn't come in with the, and you can see actually the anterior images too, there's sort of starting to become this sort of anterior wall ischemia. So what's really going on here, okay? So we took the patient to PET. So again, this is SPECT CT. It's unfair to compare, PET versus poor old SPECT, okay? But so we're going to compare SPECT CT to PET CT. Sorry, this went the wrong way. Where'd it go? Okay, so this is the, yes, rubidium images where you can see that that defect actually was there. It's a true defect, okay? And it's actually much more severe than stated in the SPECT CT images, okay? So why is this superior? Because part of it is, well, you get better attenuation correction, all that stuff. But remember, rubidium is a better physiologic tracer than sestamibi itself. So you're going to improve your sensitivity that way. Again, another image where you see non-attenuation corrected images, you have a little bit of a reversible defect in the inferior wall. You do the standard CT attenuation correction, and that defect now all of a sudden switches to the anterolateral wall. Okay, so now you've got a reversible defect. Okay, what's going on here? So let's do a PET, and this turned out to be all artifact. The PET's absolutely completely normal. Okay, so even beyond SPECT CT, cardiac-specific SPECT CT, not just that. This camera is designed to be cardiac-specific SPECT CT, or it's actually a collimator, but PET improved that picture. Okay, so then we get to myocardial quantitative analysis. We look at the global picture, the segmental picture. We want to look at the absolute stress and flows. It's not sufficient to just look at the coronary flow reserves. You have to look at there's something called the flow gradient, which you have to look at what happens to the flow from the base to apex, because the perfusion sort of falls off, okay? Near the apex, it's a watershed area. That's the most hypoperfused area, and that has certain clinical implications, but you got to look for that. Something called flow capacity, again, there's a lot of controversy around that. A lot of people don't feel it's necessarily useful to report or look at that. I think it's a good way to learn about things, especially when you get starting off. Now, some simple parameters we use, CFR above 2 is relatively normal. It is age dependent. You have to be a little careful about that. Somebody who's 42 has a CFR of 2, you have to really think, is that really normal or not? The absolute stress flows also should be above 1.8. Idea, okay? So absolute rest flows generally are sitting around 1 or less. There's implications about that. You do a rate pressure product correction. I won't get into that today. I think there's enough other cases to cover. So what is it basically? You get serial images, or actually in list mode, you get continuous imaging in PET. You establish a blood pool and myocardium based on various compartment models. You can come up with a blood flow equations. Okay, so I'm going to take some images from the literature and sort of combine our cases that we did in the community setting. So this is just an example of a normal study. So again, as the speakers pointed out, normal perfusion, negative CT for after cirrhotic disease, Stress flows, nice, okay, all above 1.8, the very nice stress. Reserve, very good. Rest is a little okay. I mean, it's in the right range, so we're good. So this is a normal study, okay? Okay, this is what I meant by splenic switch off. Again, this is just a patient. We got a random patient. You see there's a little bit more uptake in the spleen here at rest. At stress, that falls off, okay? So that's a good indication that the regadenoson actually worked. Okay, so how about this case? Normal perfusion, heavy coronary calcifications, okay? And then you see stress flows should be about 1.8. They're all down. They're severely down. Absolute flows. Reserve, also down. Should be 2 or above. They're down across the board. So again, this is from the literature. Patient had 3-vessel disease, went on to have intervention. From our side, okay, 76-year-old male. This is the easy part. Anyone want to throw out an answer what we're looking at? This is actually a SPECT part, okay? This is prone stress imaging, and then the standard supine stress and rest. Okay, so you see this inferior wall defect. And on prone imaging, that inferior wall defect doesn't go away. Now, on the rest images, that shifts a little bit. So you might think, okay, there's a little bit of ischemia, and maybe a little bit of diaphragmatic attenuation artifact because the fixed portion doesn't really match up. But that's pretty severe. You're not going to really go away believing that that is actually just a normal inferior wall myocardium. So you would think it's a fixed defect, and it's maybe peri-infarct ischemia, that kind of stuff. This is SPECT, not SPECT-CT, okay? And on PET, number one thing to note, inferior wall completely normalizes, okay? So, and that defect stays. So now this is pretty severe ischemia, all right? So already PET has shown we've got severe ischemia. Inferior wall, ordinarily you would think, okay, we're going to find disease in the RCA and that's it. But now what do we see is, again, stress really bad across the board, okay? Reserves, actually a reserve in the LED is mild to moderately decreased, mild to moderate circ. RCA is decreased, no surprise, no brainer. Okay, this is the global CFR, okay? So if, you know, when people say CFR is 1.5, you realize this is not telling you the picture. You're missing all this, okay? So you have to go through these numbers. And if you're going to start paying attention to the numbers, now look at the portal plots, see what's going on. Look at the gradient, not much of a gradient there. It should be high to low, but not here. See that? So when you start taking time to look at this stuff, you're going to spend as much and maybe even more time than you do looking at your images, because you're going to have to go back and think, okay, this, what did the image show? What did I say? What's going on here? You know? So this is really important, and the EF kind of dropped. Now, the literature suggests you should have a rise in EF. I'm a little lukewarm about that myself for various reasons. But, you know, but what basically this says is that you should look for multi-vessel disease when you go to the cath lab. Okay, so the patient had moderate severe size, severe mid-inferior wall ischemia. There's LV dilation. At rest and stress, it wasn't TID. Inferior wall ischemia was fixed, and cath showed, of course, you know, a high-grade stenosis, RCA, but the LAD and circ were normal. Okay, so you've got bad flow globally. What does that mean? You got bad flow globally, but your cath was normal in the other two territories. Anyone want to hazard a guess? Quick guess? Exactly. You have a disease with global microvascular disease. Okay? This part, this global microvascular disease does not happen without the flow component. And again, so you've got perfusion, you've got atherosclerosis on CT, and now you're adding this component to the patient's thing. So that's where myocardial blood flow comes in, and very handy in terms of the patient. Okay, just another case where a patient had a stress test, and the stress, poor numbers, the images look otherwise fine, reserves pretty bad, okay? So they're like, okay, so what's the differential for this? What's the differential for this kind of, like everything's bad? Stress, reserve, three things. I'm sorry? Vasodil? Correct. So just if you didn't hear that, is vasodilator failure, microvascular disease, or multivessel disease. Okay, those are your big three. But you can't tell based on this. Okay, so they said, okay, this could be vasodilator failure. Let's repeat the study, and sure enough, those numbers bump. Okay, they're still not normal, but the numbers do bump up, and they get better. Whoops, I'm sorry, this thing. Wow, this jumped a lot of things. Okay, so it got better, the numbers got better. Certainly the RCA is not an issue, but the LAD circ, and so again, suggesting that there may be, I don't know from the journal if they actually cath this patient or not. However, our case is, again, you see a relatively normal looking study. You see there's sort of this anterior wall stuff, but that's on the rest images. They look otherwise fairly good. See LV, a little bit of an LV dilation, baseline. Coronary artery calcifications, not much at all. They're just a little fleck, okay? But across the board, stresses don't look good. Rest, reserve, you know, so on, not much. Splenic switch off? No splenic switch off, okay? So that's an indication to me, oh, this is probably vasodilator failure. And by the way, you have no way of knowing that on SPECT. So it's estimated about 10% of patients don't have a vasodilator failure. That is a large number if you think of the number of patients you're doing. So stress is better than rest perfusion. So you know, we said it's a vasodilator failure. Would you like to repeat this? Like, no, we're just taking the patient to cath. Cathed them, 100% CTO at ostium, but the patient had collaterals. LC, circ and RCA was normal. They did not intervene, okay? So there is disease, but again, it's a regadenoson failure. Okay, 50-year-old male had a previous calcium score of 589, hyperlipidemia, mother with CABG in her 50s, having chest pain, relatively normal study, agreed? Relatively bad numbers across, okay, actually there's, it's a relatively normal study actually, but if you look carefully, there's a little bit of a defect in the anterior and inferior wall. And that seems to be a little reversible when you come down here, and it almost looks like it gets brighter in the septal region. So it's like, okay, well, maybe there's something there, maybe not, okay? And then we look at the numbers. Stress, all above, more or less above 1.8. It's mildly decreased in the RCA, but your reserve is very good, okay, across the board. So actually, and EF jumped up nicely. Again, look at the pleural plots, okay? There seems to be a little bit in RCA. There's a little bit of an issue in terms of the gradient, but the gradients in the other areas look very well. And in fact, the reserve in that septal wall seemed to be even better. So again, putting it all together, and oh, by the way, there are coronary artery calcifications here, and it's actually fairly severe because it's a multivessel disease, LAD, RCA, circ, okay? So it's a relatively normal scan. It was felt that, okay, that was probably a little bit of a motion artifact. We didn't really pick it up on the sinograms and stuff like that. By the way, the techs really should be watching and monitoring the patient while the patient's in the PET scanner, because you could have motion, not necessarily motion that way, but funny breathing or things like that, which could give you different motion issues. You know, the person is getting vasodilator in the PET scanner. There is the issue of claustrophobia, right? So the patient may be a little bit more anxious and things like that. So they have to be watched and monitored really carefully. So again, possible motion artifact. You could argue there's a little bit of mild endothelial dysfunction, circ and RCA territories, but really no ischemia. Okay, so we have, how do I say endothelial dysfunction without ischemia? Is because your reserve is fine, right? So reserve says there's no ischemia there. But your flow, your absolute flow isn't quite normal, okay? So you don't have good flow in there, but the vascular bed can compensate. So here, the myocardial blood flow actually help us determine that, yeah, this is probably an artifact that we're looking at, okay? So again, another small way an MBF helps. Again, from the literature, you see inferior wall defect, reversible defect, ischemia, stress is bad across the board, reserves are pretty good, okay? You get, again, I'm deliberately ignoring the global number. The global number would say this is, if you do the CF, that's what my cardiology colleagues started doing when they read PET. They say, oh, CFR was 2. It's like, no, you can't do that. It's a global number. There's a certain prognostic significance for the global number, but you have to go down into the depths of what you're looking at. Okay, so the point being is that even though the global number is down, it's, you have to kind of look at the individual regions. So our case is similar in the sense that you have an anterior wall defect, reversible defect, you can see it. It's a patient with a history of cabbage. You may recognize that kind of defect. It's very selective in the anterior wall, but it's clearly there, okay? And then you look at it, heavy coronary calcifications with cabbage-related changes. You've got other atherosclerosis. You actually also have calcified nodes there. Look at the polar plot. You've got decent gradients here. Maybe not so much in the LAD and RC, LAD and circ territories. Sure enough, if you look at the stresses, they're kind of down in the LAD territory, but the other areas are normal. Okay, so even if you just, here, reserve is 3, you could walk away as like, oh, patient's normal. Actually, the cardiologist who read this came to me, he's like, I don't understand. CFR is 3, and yet I've got that clearly ischemic defect. It's like, come on. You know, you can't be serious. You have to, but if you look at the reserve of the territory, those are normal too. Your tip-off is really just this number right here and your polar plots. Okay? So again, when you're looking at flow reserve, don't just look at, just take a number and run with it. So we see that there's actually a small defect anterior wall, and there's something moderately severe mid-distal peri-infarct ischemia. There's also small mild basal septal wall ischemia. I didn't really show that, which was, if you look back here, there's a little bit of reversibility. Okay. So I said, look, at the end of the day, this is not LAD, it's not a big thing going on. There's probably some septal perforators and things like that, and at risk, and the CFRs are pretty normal, so your risk stratification is pretty good. So again, here CFRs are pseudo-normal, okay, if you just kind of look at numbers. I tell my residents, anyone who walks through, I said, you know, nuclear medicine, we generate a lot of numbers. Ejection fractions and, you know, renal functions, split renal functions and all that stuff. I said they're all nonsensical. They're all nonsensical unless you can put it into the proper context of what you're doing. So again, CFRs are pseudo-normal, but they are focally decreased in areas of defect. So again, so it's likely some sort of septal perforator and stuff. At the end of the day, decide not to do anything with the patient. And again, this sort of highlights this from the literature where all those numbers are normal, but only these numbers in here are abnormal. And if you're not paying attention, because this is all above 1.8, except there's a little bit of LAD thing here, you know, you could totally miss it. And it would, or rather, it may not make sense. It may not make sense to you. It's like, how can the CFR be normal? You know, because the clinician may ask you that. In fact, cardiologists who are not reading PET will ask you, it's normal. What are you talking about? You know, so. Okay, 81-year-old male, we see that there's a little bit of TID. I think this is the case. And in fact, if you look at the blood pool at rest, there's a little bit of leftover. At stress, the blood pool goes away, okay? All right, so heavy coronary calcifications, has LVH, has stress is all down, reserves are good, but the stresses are down, okay? And you look at the polar plots, yeah, there is a sort of gradients there. The gradients are there, but it is globally down. EF is poor, okay? So 14 to 23%, It's went up from 14 to 23%, but obviously has a cardiomyopathy underneath. But the reserves are good. So findings, no epicardial or microvascular ischemia or infarct, because why did I say no ischemia? There isn't anything here. The flow is bad. That's not ischemic. That is endothelial dysfunction. Dilated LV, you have heart failure with reduced ejection fraction, severe coronary artery calcifications, there's microvascular disease, endothelial dysfunction. Cath just showed a distal OM 90%, okay? LAD 75%, other small non-critical lesions. They decided to do just medical management, okay? So despite everything, you see some issues, but it's not there. So again, non-critical coronary artery disease, microvascular dysfunction with dilated cardiomyopathy. And there was a question, actually, if the patient had had a baseline dilated cardiomyopathy to begin with, on which there is superimposed coronary artery disease, okay? Again, that's the kind of thinking that we don't really think about in standard SPECT imaging. This is from the literature. Again, it shows you a big infarct, maybe a little bit of infarct ischemia. The reserve in the LAD territory is not bad, it's down. But the point of this case is, what is the reserve actually? It's literally the ratio of this number to that number. That's it. That's your reserve. So if you've got bad perfusion, it's kind of like 0 divided by 0. Okay, and well, 0 by it's not going to be it's not going to be 0. It's going to be a number. And then you say, oh, that's not so bad. Well, no, it is bad because you just don't have perfusion. So you don't believe that LAD number. This is where the polar plots may help you, where you start breaking the myocardium into different parts and looking at it. But again, this is, don't just believe the numbers. Look at your images first and then go to the numbers. Your numbers should help you interpret the images, not the other way around. 94-year-old guy with known dilated cardiomyopathy in this case. And again, relatively normal perfusion. And by the way, I do call this a normal scan because that's within the limits of testing. It is a normal scan. You can't deny that. Like if something else is abnormal, like because the stress testing for it shows it's a normal scan, but abnormal stress testing, recommend whatever, catheterization or whatever else. But I can't deny the scan is not normal. So this is the black and white version. So this actually, we do see a little bit of an anterior wall defect here. Is very, very, very slight. It's the black and white version. This is the color version of it. You can see a little bit reversibility. It seems very, very mild. And the LV is dilated. We see heavy coronary artery calcifications, okay? Again, stresses are down, not terrible, but down, mildly in the RCA, and understandably, LAD region's a little bit down, flow, reserve, borderline low, it's just a shade below 2.0, and RCA is 2, so we're good. EF is a little bit down, 37 and 44, not surprising because the patient has an underlying dilated cardiomyopathy. Okay, so what does that mean? Large anterolateral wall ischemia, dilated LV, reduced stress flows, CFR Zabali decrease. Cath showed just 50% in the LAD, so no other significant regions. So LV function is disproportionate to the level of ischemic disease. Excuse me. So again, non-ischemic dilated cardiomyopathy with mildly obstructive ischemic disease. Okay, and then there's endothelial dysfunction, some level of endothelial dysfunction, because again, the degree, we're not really seeing that much ischemia here. It's mild to moderately decreased, but so they've got several things going on here. It's not just ischemia or not ischemia. Another one, this patient has moderate coronary artery calcifications on the CT. Not really seeing that much. And perfusion, same thing. Everything looks down. It's not normal, at least. Gradient is okay. Went on to have a cath. The EF didn't rise that much, but LED was patent. There was a little bit of stenosis in a D1 branch. RCA stenosis, not much going on at all on the cath, okay? So the patient did go on to have a cath, and so this is predominantly microvascular disease with significant, there is, stenosis in distal small vessels. So it's there, but it's low consequential. They didn't intervene. They felt medical management would be the best. Low consequence obstructive disease. So we did, but, bad prognostic signs. TID, which would suggest subendocardial ischemia, possible small apical ischemia as well, and overall prognosis, despite everything, is decreased. Okay, and there's a common thing that, how does CFR relate to FFR? They're not the same things. And in fact, some studies have looked at it that overall PET CFR may have better diagnostic value compared to even CT-FFR. 63-year-old male with cardiomyopathy, lots of problems. Calcium score not that bad. You see a lateral wall ischemia, sort of anterolateral, lateral, comes to inferior lateral wall ischemia. Circ is bad, not surprisingly. Flows. Reserve, not great. Reserves are down all across the board. EF is bad. In fact, it went down, okay? So here, in this case, severe 90% stenosis of proximal OM1. They stented it successfully. Normal LV function, EF was fine. But again, that was the only area that stented. They didn't see anything else in other territories, even though those were down, right? So this is moderate severe ischemia, basal and mid-anterolateral, drop in EF, globally decreased myocardial blood flow. So this is obstructive CAD, again, with diffuse microvascular ischemia. Okay? So again, we're adding things, we're beginning to understand things and add to the management of patients far, far more than just looking at the images alone. And there have been guidelines out for quite a while in terms of how to approach patients when, not just with what the images look like, but how your flow reserves look like, and going down that pathway. And now, as was mentioned, fluoroperidase has just been approved. O15 is also in the works, will be only at very specific sites. But again, as I mentioned, you have sestamimide and tetraphosphamide here in terms of your blood flow response, and rubidium is better than those, so you'll get better evaluation, but you get even better evaluation of fluoroperidase and O15, which are near unity or almost like the ideal perfect tracers. So, we might be able to even pick up even more disease. So, in summary, PET images improve appropriate identification of epicardial disease, okay? The MBF numerical analysis should be evaluated as much or more diligently as the imaging component. So you have to really, really break it down and go into what's going on. Cath may still be needed, despite the cardiologists, I don't know a cath. No. Why? Catheterization of abnormalities or normal areas. Because what you want to do is you want to characterize what you're looking at. So I told everyone you need to think of cath as an added tool. You have to get away from this concept of false positive, false negative. It was abnormal the flow was abnormal. It's an abnormal study. I don't care what the cath shows. The cath just tells me, is it obstructive or non-obstructive? Those are the things that's added, okay? So PET with myocardial blood flow helps find and further characterize the heart disease. Could it be non-ischemic dilated cardiomyopathy or not? Add that in. And again, it's part of a multimodality imaging approach. So some people, I say, okay, coronaries look clean, you know what? Go ahead and get a coronary CTA as a follow-up. And we haven't gone back and seen, how many we've looked at our patients who got cath. We haven't seen how many have followed up and got coronary CTAs. But really, we can't take this modality in isolation. It has to be as a multimodality approach, and which cath is a part of. We have to get away from the paradigm that this is just a gatekeeper to cath. It is not. It is a gatekeeper, but that's not the only reason. And sometimes we need the cath to further define what's going on. And with that, I believe we can go to the Q&A session.
Yes.
Thank you. Appreciate it.